Hello, my name is Dr. Diwan S. Raja. Today I will discuss about keratoacanthoma. Keratoacanthoma is a rapidly growing dome-shaped skin tumor that clinically and histologically resembles well-differentiated squamous cell carcinoma, but often has a tendency for spontaneous regression. So let's get the definition again. A low-grade, rapidly growing epithelial tumor derived from pilosebaceous units, sometimes considered a variant of squamous cell carcinoma, but debate continues whether it is a distinct entity. Epidemiology of keratoacanthoma, common in middle-aged or elderly individuals, more frequent in fair-skinned persons with chronic sun exposure. Male has more tendency to develop keratoacanthoma than that of the females. Risk factor: ultraviolet radiation, sun exposure, immunosuppression, organ transplant, HIV, infection, chemical carcinogens, tar, pitch, genetic syndrome, Muir-Torrey-Ferguson-Smith syndrome, HPV association in some variant. Clinical feature: classic lesion, solitary, rapidly enlarging, dome-shaped nodule with central keratin-filled crater. Size usually 1 to 2 centimeter but can be larger. Common sites: sun-exposed skin, face, forearm, hands, and neck. Growth pattern: rapid growth phases 2 to 6 weeks, play to phase, regression in months. May ulcerate but rarely metastasizes. Okay, this is the keratoacanthoma. This is keratoacanthoma on the dorsum of the hand, but it may happen in other sun-exposed areas like face, on the ear, on the upper part of the chest or upper part of the back. So this is the clinical photograph, histopathological photograph B, C, D. A crater filled with keratin will get crater filled with keratin, pale glassy appearance cytoplasm with neutrophil abscesses in C, and dyskeratotic cells and minimal atypia in D. So these are the features. So like a volcano, a crater, keratin here, rapid growth, then usually regresses. Variant, we have common is the solitary keratoacanthoma, most common. Multiple keratoacanthoma is seen in Ferguson-Smith syndrome. Giant keratoacanthoma greater than 2 centimeter. Subungual keratoacanthoma, mucosal keratoacanthoma. Histopathology: well differentiated squamous epithelium with a central keratin plug. Leaping of epidermis over crater edge. Buttress-like. Glassy eosinophilic keratinocytes. Minimal atypia. Cannot always be reliably distinguished from squamous cell carcinoma. So clinically it is very difficult to differentiate in many cases with squamous cell carcinoma. So biopsy is the answer. So we should go through histopathology. Differential diagnosis, squamous cell carcinoma, most important, basal cell carcinoma with central ulceration, molluscum contagiosum, a melanotic melanoma, and cutaneous horn. These are the differential diagnosis. Management, excision is a treatment of choice because histology cannot be reliably ruled out squamous cell carcinoma. Alternatively, curettes and electrodesiccation, cryotherapy, intralesional methotrexate or 5-fluorouracil for multiple recurrent keratoacanthoma, oral retinoid in syndrome like Ferguson-Smith syndrome. So this is a vitamin A derivative. Prognosis, generally excellent prognosis. Spontaneous regression is possible in many cases. Recurrence is rare after complete excision. Important to treat since some may behave aggressively like squamous cell carcinoma. And that's all about keratoacanthoma. If you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe. Have a nice, wonderful, and blessed day. Bye now.